Thank you everyone for coming this evening. So myself and Amy will be talking about genetics and how, genetic testing and genetic counseling also applies from like a medical perspective, and also how it kind of applies to, pharmacogenetics and medicine and all of these things, how it just kind of all incorporates together. So when you think about genetics, a big thing that a lot of people think of is Angelina Jolie. So it's been about 10 years now. Angelina Jolie kind of came out with some personal health information and said, hey, I have this strong family history of breast cancer. I've done some genetic testing and I have a BRCA1 mutation. And so because of this, she was able to kind of change her health and medical management and actually opted to have bilateral mastectomies. So she did this preventatively, but with genetic testing, she was able to find that information out and kind of tailor her medical management because of that. And so from here, Amy is just going to kind of go into a little more detail on kind of the sciencey side of BRCA1 and what that gene is and that we all have it, and give a little more detailed examples.
And so sometimes people hear the word personalized medicine, and sometimes people push back on that and they say, well, isn't all medicine personalized, right? You see a doctor and he or she is treating you. But in fact, personalized medicine goes one step beyond sort of this one-size-fits-all approach to making medical decisions. It's actually looking at your DNA and finding out how you're different from someone else who might have the same diagnosis. And that's what we're going to talk a little bit about tonight. And the reason why I usually call it science is sometimes people think about this as almost science fiction, right? Like where you can look at the DNA and do all of these crazy things and you can predict your future and you can do... There's plenty of science fiction, but there's actually quite a bit of real actionable science that's available right now. And a lot of times being able to access that information comes in through genetic counseling, which Kassi will be talking about in a second. So under this umbrella of personalized medicine, there's all kinds of different things you can do. You might have heard about sequencing, like how much does it take to sequence all my DNA? Sometimes people are thinking about diagnostics and using your DNA to be able to diagnose yourself, risk assessment for different diseases, pharmacogenomics and genetics, which is what I research. And so you could be really looking at any number of these things under that umbrella. So we're going to focus on some disease things today. So BRCA1, which is, I'm guessing you probably have heard of before tonight. It is a gene that everyone has. So sometimes people say, oh, do I have the BRCA1 gene? The answer is always yes. Everyone, male and female, has a BRCA1 gene. And normally this gene helps repair DNA damage. So our DNA gets damaged all the time just from normal things that we're doing. And BRCA1 is one of the genes that helps repair that damage. And so it's called a tumor suppressor gene because it helps suppress tumors from growing. So you can imagine if you have a BRCA1 gene that doesn't work at 100% efficiency, your ability to suppress tumors is going to be compromised, right? And so the idea that, do I have the BRCA1 gene? Yes. The question is, do I have a BRCA1 gene that's operating at 100% or maybe not 100%? And so this gene is really large. It's over 110,000 base pairs. And so if you've ever done 23andMe testing, I don't know if any of you have done that, but BRCA1 is one of the things you can actually get a report on 23andMe. And they look at 3 bases in the BRCA1 gene and then tell you whether or not those 3 bases are normal or mutated. And so they picked arguably 3 of the most common spots in the gene that cause problems. But if you think about over 110,000 bases, really if you have a problem in any of those 110,000 bases, you're going to have a compromised BRCA1 gene. So just looking at those three isn't really giving you the same medical information that you'd be able to get if you actually had a medical test done or went through a genetic counselor. And so that sometimes gives people a false sense of security because the three variants that they're testing for are common in different populations, and whether or not you share ancestry with those populations could affect how useful that information is for you. But the best way to actually find out about your risk here would be to talk to a genetic counselor or your doctor, who might refer you to a genetic counselor if there's other signs in your family history that might suggest that you're at risk for this. So something else where sort of everyone maybe is aware of genetic testing is sort of prenatal genetic testing. So this has grown a ton in recent years. And so there's really two primary types. And I'm going to kind of go in opposite order than they are on the slide. So carrier screening actually looks at your DNA to see if you're carriers for things that are relatively rare, but are recessive things. So things that you would never know just based on your own physical traits, but that you could be a carrier for, and if you're a significant other that you're having a baby with was also a carrier for, that your child could be at risk for inheriting. And so this is something, carrier screening, you could actually do at any age. You could do it before you're even thinking about getting pregnant. You could do it at any point when you start trying or you're thinking about trying for a baby. You could check out carrier screening. And this is often done on the mother. And if there's something that shows up, then they'll test that variant in the potential father to see, oh, are you also a carrier? And you might be thinking to yourself, well, if these things are really rare, what's the point in doing that? Rare, when we're talking rare, we're talking about really unlikely things to happen. So, it's not real likely I'm going to win the lottery, so why would I be taking precautions for something that's unlikely to happen? In fact, rare things are not, so in Caucasian, rare varies by your ancestry, I guess, is maybe the shortest answer. And so if you think about Caucasian individuals, which scanning the room is probably the most relevant ancestry for this group. 1 in 23 Caucasian individuals of northern or European ancestry are carriers for cystic fibrosis. And so there are maybe not quite 23 people in the room, but if you're in a room with 23 people, probably one of them is a carrier for cystic fibrosis. And if you're in a room of 100 people, there's probably 4 or 5 carriers for cystic fibrosis. And if you know someone who's had cystic fibrosis, it's not exactly a death sentence anymore, but it's a pretty compromised existence, and it affects your ion channels and your ability to breathe in the lungs. And so 1 in 23 is not that rare of an instance, even though you likely don't know anyone with cystic fibrosis in your day-to-day life. So that's something that you could actually test for ahead of time. And this is something that 23andMe offers. If you've done that, they have a carrier screening page. And again, what they give you is accurate. Sometimes people call me and ask, well, is it real? Is what they're telling me like the real deal? And it is, but it's oftentimes incomplete. So the gene that causes cystic fibrosis, they test for, I think, 3 or 5 of the most common mutations, but any mutation in there is going to cause a problem. So again, that might be something that you'd want to consider doing through genetic testing. And then NIPT, non-invasive prenatal testing, this is actually looking at the DNA of a baby before they are born. It's a panel of looking at a lot of common variants and can provide information that would allow people to either make decisions or adjust plans depending on what might be found so that they are not surprised. It doesn't change anything. It's just looking at the DNA to let you get a head start on diagnoses that might be coming down the road. And so I want to end my first introduction here with pharmacogenomics, which is sort of my passion and what I work on. And the reason that I love it so much is because I think it's really accessible to people. So when you have a group of people that get the same diagnosis,
and they get the same treatment. And this is true whether we're going to be talking about asthma or we're talking about even something simple like a headache. You have a bunch of people, they all have a headache. Well, if they all take the same drug, Tylenol, you're going to have some where the drug is not toxic and it's beneficial. Their headache goes away. This is the group of people you hope that you're in. You're going to have some people where the drug itself might be toxic. So maybe it causes you to have a stomach ache, but your headache goes away. So that's sort of a risk trade-off, and that's something that you might learn over time where you sort of decide, well, I know if I take this, it's going to cause this other problem, but it's going to fix the problem that I'm trying to deal with. So that's not the worst group to be in. Then you're going to have some groups where you take the Tylenol, the headache doesn't go away. It doesn't cause any side effects, you don't get a stomach ache, nothing's wrong, but whatever started, still there. And then you get the last group of people where the headache doesn't go away and you get the stomach ache and you're sort of in a worse spot than when you started. And so a headache is a really benign example, right? If you think about that, these 4 groups actually exist for pretty much every treatment that is given. So whether we're talking about asthma or cancer or any treatment that involves some type of pharmacology agent, all 4 of these groups are present and the size varies. So sometimes this group is the biggest, which is obviously where you want to end up. But in a lot of cases, that top group is bigger than you might think. And anything that we could do as scientists or clinicians or providers to help you know which group you're in before you take that compound would be beneficial. So if you knew this drug is going to help you, but you're going to have a really bad side effect, then it's sort of an informed choice where you could say, yes, I still want to take it. If you know the drug is not going to benefit you, you might say, I'm going to opt out of this treatment because I know there's really almost no chance of helping me, and all I'm going to do is get these other side effects. Especially when we're in things like cancer, where there's lots of different chemotherapy that you can have, this is really beneficial. So this example is kind of fun, but it's also scientifically accurate. So caffeine actually is a drug. You might not think about it that way, but it is. And it helps us feel more awake. It affects our neurotransmitters. That makes you a little bit more alert. And genetic variation in a specific gene, CYP1A2, affects how we break down caffeine. And this actually is hugely polymorphic. So sort of like when you look at people and you can see that we all look different, different colors, hair, different height, all of those things, it's just as different on how we break down caffeine. And so there's a greater than 12-hour variation between how people can break down caffeine, which if you think about it, 12 hours is like half a day. This is why some people, you maybe know them, if they have a coffee after dinner, they're like, I'm up all night, I cannot go to sleep, it doesn't matter. And they know not to have coffee after a certain time. It's also why some people mog the coffee, like can drink 4 or 5 cups, and you're like, oh my gosh, how does that person ever sleep? They're probably on that faster end of the spectrum where their body is breaking it down much more quickly. And this is completely different than the tolerance, which with any drug you can sort of develop, where maybe that first cup of coffee doesn't give you that same jolt because you have one every day and your body develops a tolerance. This is completely different than that. This is breaking down that active chemical. And so this is true, again, for more complicated drugs than caffeine. And so I'm going to end with a quick example in oncology, but I want to give you just a little bit. This is a little bit of an outdated figure, but I love it, and I haven't found a better one that's more updated and still basically true. If you look at these different therapeutic areas on the left, the effective rate is the percent of people that were in that group that I showed you at the beginning, where the drug is beneficial and there's no bad side effects. And if you look at it, the effective rate for these categories, which probably most of us feel like have good treatment options, these numbers are crappy. I mean, they're not great. You would want these numbers to be 100%, or you'd want them to be really close to it. And in oncology, it's 25%, which is, and it's maybe gone up a little bit since this figure was made, but not a lot. And so just to kind of run through this final example, and then Kassi's going to pick it up with some local examples that she's seen here. This is a 48-year-old woman who's diagnosed with triple-negative breast cancer. And so triple-negative breast cancer means it's not responsive to different hormones. And you can kind of see the mass there. So for triple-negative breast cancer, the majority of respondents go towards taxane-based therapy. There's no proven treatment for triple-negative because there isn't a specific hormone that you're targeting, but taxane is really common, and so paclitaxel was decided for this patient's breast cancer treatment. So this is a really good sort of visual. You can see the tumor up there in white. And so they underwent 4 cycles of paclitaxel. Each cycle is about a month long. And there's no change in the tumor size. If you look at the before treatment and the after treatment, you can see the tumor is basically untouched. Paclitaxel is extremely toxic to the liver. So these 4 cycles of paclitaxel has given them liver toxicity. So they're now being treated for that. So they're now sort of in worse overall health than they started because they now have liver problems and a tumor in their breast. And at the end of these 4 cycles, which is basically like 4 months, they've shown no progress in their treatment. And this is obviously disheartening, right? This is not the scenario you want. So they decide to take another treatment, this adriamycin cytotoxin, which is another sort of profile at the beginning. These are sort of interchangeable. There's no evidence why one is better than the other. So they decide, well, let's try this treatment. This first one hasn't responded. And if you look after the treatment with this new protocol, you can see the tumor on, let me see if I can get the, so you're comparing before to here, it's obviously shrunk a great deal. So if this patient could have known from the beginning that this treatment profile would be much more beneficial to her, there's no way she would have wasted 4 months on the wrong therapy and developed these liver problems. And so the idea of being able to predict this, there are plenty of people where the opposite would have been true. That's why taxane was the first, or paclitaxel is what normally is tried. More people have the better outcome with paclitaxel, but there are people like this that would be better off if it had been flipped. And so that is why genetics is such an interesting thing to be able to study, because if you could do a test on your DNA to say, this drug combination would be better for you than that combination, you could get to this ending point without the trial and error involved. So I will hand this over to Kassi now for the second bit of local examples.
All right, so I'm Kassi. So I'm a genetic counselor at Beacon Health System. So as Amy gave kind of the more technical side of things, I can kind of bring it in a little more locally. So I've been here for about 4 years, and these are just a couple of case examples that I actually have seen myself with local families. So my first example, I'm going to stick to oncology, kind of carry that theme through. And so I saw a healthy 35-year-old female. She came to me solely based on a family history of cancer. She had never had any major health concerns, no personal history. But as I kind of listed up here, her mom had a history of breast cancer, an aunt with breast cancer, and then a maternal grandmother who had thyroid and breast cancer as well. And so naturally, we of course tested for BRCA1 and 2. That is always where our brains go when we see that strong family history of breast cancer. But what a lot of people don't really know is there's actually a bunch of different genes that can cause these increased cancer risks. So BRCA1 and 2 are very much the most popular, as Amy mentioned, because of Angelina Jolie. But when we do this testing, we do it in the form of a panel. So we were able to offer this patient this large comprehensive testing, and she was found to have a change or a mutation in a gene called CHEK2. And so with this gene, we know it can cause an increased lifetime risk for female breast cancer and colon cancer. We also know there's some evidence it causes an increased risk for thyroid and renal cancer. So with this information, even though she was completely healthy and had had no history of cancer, she now knows that she does have an elevated lifetime risk over just general population. So with that, kind of the really cool thing about this testing, because some people, they ask, why would I want to know that I have these very high increased risks? Well, these genes have established medical management recommendations. So, we find this information out and we're able to alter how a person's screened and monitored. So luckily for this patient, she was able to start increased breast screenings starting at a younger age, also starting colonoscopies at a younger age and with a higher frequency. With that, she was also able to take this information to her family members. So she's someone who had 2 daughters and a son. She had, multiple siblings. Her mom was still living. So we were able to then offer that testing to quite a few of her family members. So they were also able to be a little more proactive in their overall health. But besides cancer, I actually do general genetics, so I see patients for quite a few different things. And a really common one that a lot of people don't really know can have a hereditary or genetic cause is high cholesterol. So about 1 in 200 people have some kind of hereditary cardiac condition, and most of those are a form of high cholesterol. So not uncommon, something that a lot of people are treated for, probably even in this room. But when we see someone diagnosed at young ages or who has kind of a hard time managing it, even with diet, exercise, medication, then we can offer testing to see, is there some kind of genetic cause going on? And so this is a patient that I saw. She was a 21-year-old female. She began having high cholesterol diagnosed at 17, and she also had the really extensive family history. So we were able to offer this testing, very similar. We did a bunch of genes, a big panel, and she was found to have a change or a mutation in a gene called LDLR. And so, it kind of helps alter that medical management in a different way. So we don't have any screenings or things like that, but it can help with medication decisions. So kind of going back to the pharmacogenetic world, it can help, primary care physicians make those decisions of what medication is going to be the best. And it also helps with family members. So this patient actually had a very young daughter. We were able to test her in childhood. She already had high cholesterol in very early childhood. So, now mom knows we need to make sure she keeps a very active lifestyle, healthy diet, because if we're already having that high cholesterol at such a young age. And then my final local family example is another cardio. So I see quite a few cardiac patients, and this one is a little unique. So this patient was a 40-year-old female. She actually had experienced sudden cardiac arrest. She ended up being fine, she was treated, and she was diagnosed with something called long QT syndrome. So basically that's just an abnormality in the rhythm of the heart. And so she had that clinically diagnosed, and there's a bunch of different forms of long QT, and there's a bunch of different genetic causes. So she was sent to me to figure out the genetic cause so her children could be tested, because she had 3 or 4 kids and lots of siblings. And so we tested her, again in a really big panel, because that's just what we do. And she actually was found to have a change in a gene called DSP. And this does not cause long QT syndrome. It actually causes something called arrhythmogenic right ventricular cardiomyopathy. So it's a form of cardiomyopathy, which is disease of the heart muscle. So it causes a lot of similar symptoms to long QT syndrome, but it's actually an entirely different condition. So we were able to get her the correct diagnosis, make sure she had the correct medical management, and then also test her very, very large family, which made a really, really big difference because a lot of them ended up testing positive. The kind of interesting and scary thing with the cardiac conditions is, it doesn't mean that you'll ever develop cardiomyopathy. They're all pretty variable. So some people may be unfortunately severely affected, like my patient, whereas some people may go their whole lives and remain asymptomatic. So Those are a few of our local examples. And then just kind of a brief overview of, I've been giving these examples, said what I do, but what does that really mean? So a genetic counselor is someone who kind of facilitates all of this. So I meet with patients, I discuss the psychological, the medical, the familial impacts of all of this information, the genetic testing, the medical management. How do we get the genetic testing? So I order it, interpret it, all these things. And so I'm kind of like a go-between between patients and physicians of being able to facilitate all of that and kind of provide those medical management recommendations for individuals. But also the other side of that is families. So this type of testing, it's, kind of different than a lot of just normal testing you do because it does impact more than just yourself. So parents, siblings, children, aunts, uncles, all of these people can be impacted. And so a big part of my job is family testing, not even just my patients, but a lot of the times I end up getting to know huge families in the process. So what happens if you came to see a genetic counselor? So we go over detailed family history, medical history, and then just kind of a deep dive into what you're there to see what I'm there to see the patient for. So cardiac focused, cancer focused, and we just really go over testing options, what's right for the patient, if testing's right for them at all, and then always offering support and resources. And a big thing that I always like to mention whenever I talk to anyone about genetics, just kind of my little plug, because this is probably one of the number one questions I get asked, is how would this impact my insurance, right? So there is a law in place. It's called GINA. It stands for the Genetic Information Non-Discrimination Act. So this law is in place to protect patients from discrimination with health insurance and employers. GINA does not include life insurance, long-term care, or disability. Doesn't mean any of those would ever discriminate, but they are legally allowed to ask. So I do get that question quite often, and I always like to just answer it in advance. And then with results, once those results come in, they come to the genetic counselor, and the genetic counselor interprets them and goes over them with the patient. So whatever they may be, if they're positive, we found something, we go into that detail. Negative, we didn't. That's good. And then there's always, unfortunately, this annoying option of getting something called an uncertain result when we do genetic testing. It basically just means they found something but aren't exactly sure what to do with it. So with those, we do just typically treat them like a negative result and move on with our lives. And who may benefit from genetic counseling? So honestly, anyone who is interested. You don't have to have a personal diagnosis of something. You don't have to have a strong family history. Some people just want to know. I get a ton of patients who come in and they're just wanting to be more proactive. This is becoming a little more commonplace. And so that is completely acceptable. Other things that, some people might not think of is not having any information about your family history, being adopted. You can't know what you don't know. And so some people kind of want to try to find out a little more about themselves. And then the other thing is having a lot of things in your family and not really knowing what to do with it. Is this hereditary? Is it not? Should I be concerned? And that's another thing we as genetic counselors do. We go over that info and kind of help dissect what could and could not be hereditary. And like I mentioned, there's a lot of different specialties that can be seen by a genetic counselor, not just the ones that myself and Amy gave examples for, but oncology, hematology, cardiology, prenatal, neurology, metabolic, and so on and so on and so on. So just my final for your local resources, genetic counseling at Beacon Medical Group. So as of right now, it is just me. I do see patients at both Memorial Hospital in South Bend and Elkhart, General Hospital in Elkhart. Those referrals, if you yourself, anyone family members, if anyone's ever interested in genetic testing, genetic counseling, or honestly just has questions, I'm always happy to chat. And referrals can always be, sent by a primary care physician or just self-refer. And how to start that conversation. So I find that a primary care physician is a really good place to start. So usually just asking, is this something that would be appropriate for me? Or more importantly, this is something I'm interested in, how do I go about it? They're usually a really, really good starting place. And just having some of those questions of, I'm concerned about this in my family history, or I really want to know more about my family or myself, and kind of really personalize my own medical, management going forward. And now I will pass back.
Wraps up sort of our prepared remarks. We want to spend as many time answering questions as possible. The DNA Center at Notre Dame has a lot of summer programs if you have kids that might be interested in learning more about genetics. The one thing I wanted to highlight in the pink box is the Ancestry Workshop. That's actually for anyone middle school or older, so adults are welcome to that as well if you want to learn more about ancestry in that workshop, and you can always go to our website. But we've had a lot of success training the next generation of people who might be interested in genetics. So if you have kids, grandkids, anyone you know that might be interested in science, we'd love for you to send them our way. They come from all over, so we have residential camps. We've actually had a few come internationally because it's such a unique program, but we would love to welcome you to campus. And so with that, we would love to answer any questions you might have about genetic counseling, genetics and disease, or anything really under the broad category of genetics that probably Kassi or I might be able to.
We can try.
That might be able to help you with. Yeah.
I have a question for Kassi.
Yeah.
Insurance-wise, if you go for counseling, genetic counseling without a referral or without a specific concern, how do insurance companies handle that?
Yeah, no, that's a really good question. So I can only speak to myself locally. I am in network with most insurance companies, so usually consults are covered within insurance, just the consult part. I will say I do know that the self-pay price for a consult is $112. So if it's not covered by insurance, that's a self-pay price. But I do know I am in network with most, so even with a self-referral, usually my patients get pretty good coverage for that consult. And to kind of elaborate on that, like the testing side of things, because I know that would probably be the next question. So very similar. Usually most insurance companies do cover genetic testing now because it is becoming much more commonplace, but the self-pay price for genetic testing is $250. So that's if it's not covered or if you don't have insurance.
No, it's not expensive. I mean, and when you think about the trade-off of what you learn, potentially, there's also people in the genetics community, this is probably, Kassi can cover her ears on this part, but people who are really concerned about privacy and don't want more people to know about their DNA than is absolutely necessary, you can self-pay and sort of keep that out of your medical record if you are really worried about that, and where you're empowered with the information yourself and you keep it sort of away from your employers or medical record.
Yeah.
But it's a trade-off. There's definitely benefits for having it be part of your medical record, but you certainly would not be the only person if you're thinking to yourself, like, I really want to know, but I really don't want anyone else to know. There are ways to do that, and as Kassi pointed out, it sometimes is a little bit more expensive because obviously you're not going to get it covered with insurance if you don't want them to know the results, but we're not talking about like tens of thousands of dollars.
Yeah.
Okay, we'll go to there.
Taking that one step further, could you actually contrast this approach with 23andMe and these commercial operations, not just with privacy, but also quality as well?
So I tried to touch on that a little bit throughout the talk. So what 23andMe gives you is 100% accurate. So you can take it, there's no, it's super uncomplicated to actually look at your DNA. So that's why these tests aren't that expensive. It's scientifically simple, let's just say. So what 23andMe chooses to share with you is accurate. However, what they choose to share with you is often a snapshot, especially in those prepared reports that you're getting. So like for BRCA1, I looked it up today, they give you 3 variants. And on the panel that Kassi would probably send you for testing if you had a family history for BRCA1, for some people they sequence the whole gene because any variation in there would cause a problem. So if you're really worried about it, it's probably incomplete. Now, the caveat to that is 23andMe, at least so far, still gives you access to the raw data. Probably most people don't utilize that because they just look at the prepared reports, but there is in the settings, you could see like access my raw data. This allows you to, 1, download your file so you get all 5 million SNPs that they've looked at instead of the 35 to 50 that they're telling you about. And it also allows you to be able to extrapolate more than just that 500 because there's you can use imputation to get more variants. And there are ways that you can actually do that with your file on the internet for pretty cheap. Prometheus is the one that most people go to. So Prometheus then will give you, I don't want to exaggerate, probably 10,000 different variant things or more that they find in your genome. However, it's not curated, it's not super user-friendly, and if you don't have a degree or background in genetics, you're probably going to drown in it. That being said, if you do know someone who's in genetics, that's when you like call you up, hey Amy, I want you to look at this for me. And there's a middle ground where you can, if you see something in the news or a gene that you're interested in, you can actually query. 23andMe has like a search engine where you can look up some of those genes in more detail. So it is the full, like, it is accurate what they give you, they just don't give you everything.
I will say I have like a cautionary tale with that because I actually have had a patient who did 23andMe because of a family history of a BRCA1 mutation. And she came to me and she's like, I already did this, I don't need to do it again, but she wanted to do a full panel, so we did it. She ended up having a BRCA1 mutation. So it was one of those variants that wasn't looked for in 23andMe, which obviously was extremely upsetting, but that's always my cautionary tale to patients who ask me about 23andMe because that's my actual nightmare.
And so 23andMe for BRCA1 is probably poorer than average because it's the 3 variants that it chooses are the variants that are most common in Ashkenazi Jewish.
Yep.
So if you don't have a lot of Jewish ancestry,
you won't have it.
You won't have it. And that doesn't mean that other variants aren't as common. Like that's, I'm sure, probably what happened with Kassi's patient.
Yep.
Does that answer your question?
Yeah, I guess you might also talk about privacy as well, and the fact that,
so,
in my opinion, the way I look at it is 23andMe is, their pricing is cheap because you're the product as well.
True, that's true. But the other thing with 23andMe is you're not obligated to identify yourself. So you can create an entirely fake profile. You can put a fake name, a fake address, a fake birth date, a whole, and I know a very large number of people, and myself would be included in that have a 23andMe profile with a different name attached to it. So you can't, so you do get to maintain some degree of privacy, even though they get your DNA, they still don't necessarily get a lot of other information.
That's new. That's awesome. Thank you for sharing that.
Yes, no problem. Did you have a question on a different topic?
I did. One, Kassi, I guess, does this testing become, or for both of you either, less valuable the older the person gets? Does this modify over the years, or?
That is a great question. I get that a lot, actually. So your DNA doesn't change, right? So, you know, the results you'd get at 20 would be the same you would get at 50. But the information remains the same in terms of importance. So even if you get this information at a younger age, it's still equally as important at an older age because you could still modify your medical management depending on, you know, what you're testing for. And then also still for family members, you know, even if you don't have any family members, you'd want to have testing. It could still impact your medical management. So especially like in the cancer realm, we've touched on that quite a bit. Like that Check 2 example I gave, The breast screenings, those go all the way until the age of 75, the recommended ones. So it really does kind of carry into adulthood.
The other thing that I would add to that is sometimes your personal diagnoses and what drugs you might be taking change over time. So maybe you didn't have a real reason to do it earlier, but now you're taking a new either cancer drug or some other type of drug where genetic testing could give you insight over what dose you should be taking or what side effects that might be affecting you. So there still might be value in it that based on your changing diagnoses. Other questions?
I have a question, maybe it's more of a methods question, but I'm curious how you take the genetic information and then connect it to how you're going to respond to a drug. So is this something that they're looking at, like actually doing tests, how the drugs are interacting with different DNA forms in some kind of model system?
So
Or are you looking at correlations in the population?
So all of the ones that are FDA approved now, where it's sort of standard of care, where it's recommended that you do genetic testing, there has been a huge amount of evidence where actual variation in the protein has been shown that it affects the kinetics of the drug, so how the drug is either absorbed or metabolized. So there is both in vitro and clinical trial data that show the variant affects the response rate. So but then there's a huge spectrum where maybe some of them, there might be some studies that are correlative or some that are done in just model organisms. So there's a gradient of evidence. Depends on where you look. Sometimes they label it like A to F level of evidence. But the ones that are black box, where it's on the drug that's being prescribed, is all like that highest standard.
So when you said standard of care, can I go to the FDA website?
Yes.
And say, oh, I was prescribed this drug, I should do genetic counseling?
Yes.
Okay. Yes, okay.
Yes. I don't think a lot of people do that, but it is there. If you chose to do that, it is there.
So you go to the FDA website, type in the drug?
Yeah, or you could just Google the name. You don't have to go to the FDA's website. If you type in Coumadin genetics, it will pop right up. And it will be on the drug label.
And it is becoming a lot more commonplace. I get a lot more referrals for pharmacogenetics than I did even 6 months ago.
And you don't, I mean, you could go to the FDA website, but if you do not want to do that level, if you literally just Google the name of the drug and genetics, if there's something there, it will pop up. Other questions?
So when do you see us just going ahead and sequencing our entire being and just being able to present our business card and say, double check me against this new drug?
So that's
Good question.
So scientifically, the ability to do that at an affordable price is probably a lot sooner than you might think. The bigger problem is when you go see your primary care doctor or your specialist and you give him that business card, he or she is going to look at you like, what the hell do you want me to do with this? And they will maybe send you to Kassi, maybe try to, I don't know if we have a lot of MDs in the room, so if I'm about to insult anyone, I apologize. But they might try to intimidate you to be like, why did you waste your time with this? Like, there's nothing in here that I can use. Like, there's a lot of resistance to that because most clinicians aren't trained to be able to know what to do with that. So the idea of changing how medical education is done so that they're equipped to be able to handle that business card data is a long way away. The way medical education is changing is really, really slow, even though the technical and scientific ability to do that is not that far off.
I do get quite a few referrals from primary care physicians, especially who a patient will have done some kind of genetics, especially like raw data, like Amy was talking about from like Prometheus. And the primary care doctor will not even address it. They will immediately be like, go see the genetic counselor or go see, they're like not touching that. So.
And this is true even if you're at an academic medical center. So it's not like necessarily a small town thing. It is true kind of built in within the practice of medicine. There is not a lot of they're not well trained enough to do that. Most medical curriculums have like maybe a quarter on genetics, which is insufficient to be able to have them comfortable on how to use that information in a diagnostic sphere.
So, it seems like we have a lot of very specific answers to some very specific questions, but there's other, conditions out there like Parkinson's disease or something that can't be currently diagnosed through this type of genetic testing. What is the limitation that keeps us from being able to do that? I would assume that everything's written in the DNA at some level. We just don't understand it yet. What's going on there?
Yes, no, that's a great question, and that actually kind of reminds me of one thing that I was going to make about the timeline that I forgot. So the one advantage to waiting is that those interpretation is always changing, right? Scientific discoveries are constantly being made, and even those VUS variants that Kassi pointed out, like that for right now, you usually probably like smile and not hope it goes away, but just kind of don't do much with it. In 6 months, a year, 5 years, that VUS might be reclassified to being pathogenic or not, and that's absolutely true. There are new panels and more tests that are being developed probably literally as we're talking right now. And so some diseases like Parkinson's, where there are some genetic components that have been mapped out, it's not maybe as one-to-one as we might hope for, which is true for some other diseases, but that's just because it's more complex in nature. But discoveries are being made every day.
And I will say, I actually do see patients for Parkinson's. It's not comprehensive by any means, but when there's that family history, we actually do have a panel focused for Parkinson's right now. But like Amy said, that is constantly growing. When I first started, the cancer panel I did was like 35 genes. Now the biggest one we do is 84. So grows rapidly.
And the standard to be included in one of the panels that Kassi is talking about is that highest degree of evidence, like what I mentioned earlier. There's a ton more if you take a step down and you don't require that highest degree of evidence. And that's where you probably would be looking at if you were doing testing at like a University of Chicago or at a academic medical school where they're looking at more they're still developing the tests, if you will, so they're looking at bigger panels to figure out what should be tested on these panels that are kind of broadly disseminated.
The panels I order have like strong evidence, but then there's also a subset of genes called preliminary evidence genes, which we don't have 100% evidence, but we think they may be disease causing for whatever it is. And so I typically do not order like the preliminary evidence genes, but like you said, at bigger institutions, they always do because they just, more research, better future.
And this would probably come up if you went and saw Kassi for a genetic counseling and you had like a strong family history and she orders the panels and it comes back of we didn't find anything, but based on your discussions, you're like, we know this is hereditary. Like we really believe that there's a genetic cause, we just didn't find it in this panel. And that's where you could go to a Mayo Clinic, a Cleveland Clinic, a University of Chicago, where they might do more broad sequencing. And this is especially important in like pediatric cases where a lot of times different treatments or different interventions are important. I didn't want to step on your toes, but is that?
No, you're exactly right. Yeah, when I get a patient who has that, like I know there's something and I just don't know what it is, I either refer out or I say, please come back and see me in a couple years. So.
Other questions? Yeah?
One other one. So, not to harp on 23andMe or whatever, but like it baffles my mind that like, they have all this information, but they're presenting it to us in a limited fashion for a smaller price. Why aren't they just charging the $250 and giving us all the information like you're giving us?
So it's a really complicated question. So there's a lot of let me try and back. There are some people that think that counseling component and that support component is critically important. And it's true, right? I've had someone, she was actually a photographer that was doing some pictures for me when she heard I was a geneticist. She said, oh, I did 23andMe, and I found out I was at higher risk for developing blood clots. So now I set my alarm on my phone, and when I'm working on my computer, I stand up and walk around every 30 minutes. Now, that's not a bad thing to do for health-wise, but her increased risk was a nominal risk increase that was still incredibly unlikely to occur. And so most people don't necessarily interpret the risk profile of 23andMe correctly, which is why they need an expert or someone to be able to help them make sure they're understanding it correctly. So that's one component. Then there's sort of the business component where insurers and people who have developed these private tests don't really want the information to be going out without them to being like a gatekeeper. And then there are also people that think, that there should be some type of hierarchy to this information, that you should need to seek out some type of expert to be able to analyze it for you. I'm much more of the open, I would support people being able to access it themselves, but I definitely 100% recognize the value in being able to talk to someone about it. And because of that, there's a lot of legal pressure, kind of a give and take on 23andMe. Is it medical testing? Do you have to have a prescription? There's like that give and take in terms of how it gets regulated. And if they gave you everything, then you would probably have to see a doctor to be able to access it, as opposed to being able to do it with a fake name and a fake address and just get the information yourself.
And I will say there are other direct-to-consumer genetic testing labs outside of 23andMe. So actually, the one I use for medical genetic testing that I use for my real-life patients, they do offer direct-to-consumer genetic testing that is more comprehensive, just as accurate, the $250, and they offer genetic counseling through their website if you have questions, but you don't have to do it. So for some people who don't, like Amy said, you don't want to have to do the counseling component or talk through your results with someone, they still offer the more comprehensive testing. So,
other questions?
Why don't we thank our speakers? And thank you so much for coming out this evening. I just wanted to let you know what's coming up next. So normally we meet on the first Tuesday of each month. March is different. So in March, we are going to be here March 21st. So the third week in March. And we are going to do a mathematical dance. So Amanda Serenity, we're going to be solving fractions. We're going to create a tangle, and through solving fractions, somehow we're going to undo this tangle. But the purpose is to sort of think about creativity in math and how we can solve problems. So math dancing, March 21st. And then April 4th, Mara Lieberman, who is a chemist at the University of Notre Dame, is going to be talking about the opioid crisis. And so that's coming up April 4th. So March 21st and April 4th. I hope to see you there. And that's it for this evening. So thank you.